For patients with severe asthma, modern biologics are highly effective. The clinical outcomes from Dupixent, Fasenra, Nucala, and Tezspire mean patients get their lives back. But before a single dose ever leaves the specialty pharmacy, there is a substantial administrative barrier standing between the prescriber's clinical judgment and the patient's treatment. That barrier is prior authorization. In the asthma biologic space, this involves navigating a maze of overlapping FDA indications and rigid screening thresholds, creating a process that is notoriously time-consuming and prone to frequent denials. If you are a practice manager, a billing lead, or a physician trying to manage a high volume of these prescriptions, you are living this reality every day. Clinical expertise is being stalled by administrative friction. That friction changes the daily workflow of the modern clinic. Let's look at the actual data behind why this is happening and what some practices are doing to reclaim their time. This chart visualizes the nationwide baseline according to the American Medical Association's 2024 survey. Physicians and their staff complete an average of 39 prior authorization requests every single week. That consumes approximately 13 hours, roughly a day and a half of lost clinical time. And the success rate on the first try is sobering. For complex specialty biologics specifically, research shows initial denials approaching 51%. Half the work results in a rejection. Yet the AMA and KFF data show that when those denials are appealed, 81.7% are fully or partially overturned. The problem is, only 11.5% of denied requests are ever actually appealed. Practices are walking away from approvals they could easily win. It rarely comes down to a lack of clinical evidence. Rather, clinics simply lack the internal bandwidth to hunt down the missing documentation and fight the appeal. And the timeline is getting tighter. The new CMS 0057-F mandate requires faster decision windows from payers. While that sounds helpful, a faster payer decision on an incomplete file simply results in a much faster denial. An unworked denial queue means a clinic is leaving hard-earned revenue on the table, while patients sit waiting for care they already qualify for. Asthma biologics are difficult to approve because the class itself is highly complex. Every drug carries its own distinct FDA indication, specific dosing schedule, and highly specific screening requirement, like an exact eosinophil threshold or IgE level. Payers complicate this further by rotating their preferred drugs quarterly. They enforce step therapy, requiring patients to fail on biosimilars or alternative biologics before approving the original prescription. This diagram shows the formatting trap. If documentation of a prior trial lacks a specific date or reason for discontinuation, the payer's system rejects it, restarting the process. To break this loop, a pulmonologist must spend 30 to 60 minutes prepping for a peer-to-peer review. According to the AMA, physicians report that the payer representative on the other end of that phone line only has the appropriate specialty qualifications about 15% of the time. Having highly trained specialists spend hours every week defending well-documented decisions to reviewers entirely outside their specialty is a massive drag on both clinic productivity and staff morale. It is crucial to understand that most biologic requests are not denied because the medical reasoning is flawed. They are denied because the submission was formatted in a way the payer's automated system could not recognize. This split-screen checklist highlights the difference. A perfect outsourcing operates differently than legacy offshore labor. It utilizes purpose-built artificial intelligence to process the massive volume of clinical data required for biologics. Here's how the technology functions. An AI agent extracts unstructured chart data, like eosinophil counts and exacerbation history, and drafts a medical necessity narrative. The AI handles 80% of repetitive keystrokes. The remaining 20%, clinical judgment and complex appeals, stays entirely with a credentialed human specialist. When a peer-to-peer call is unavoidable, this hybrid system generates a concise, highly structured prep packet for the physician. It provides the chart summary, timeline, and exact guidelines needed to quickly win the argument on the phone. This approach yields a 4-hour standard turnaround time for asthma biologic requests, with expedited submissions going out in under 60 minutes. The technology is not replacing human oversight. It gives human specialists the operational speed required to match the scale of the payer's automated denial algorithms. With regulatory changes shrinking the decision windows for payers, the documentation burden on clinics is going to steadily increase. If you operate a low-volume clinic where prescribing an asthma biologic is a rare event, maintaining your current in-house process is likely the most practical choice. However, if you manage a mid to high-volume group where physicians are losing hours every week to prep calls and unworked denials are piling up, evaluating an outsourced AI-augmented model makes financial sense. Because most of these services offer short-term live queue pilots, your practice can test the actual throughput and accuracy on your hardest payers for a few weeks, without committing to a long-term contract. Solving the PA bottleneck secures clinic revenue and ensures patients begin their treatments without unnecessary delay.